nasal sinus x-rays, just the names, they've been asking this a lot. So what is this here? When you see the maxillary sinuses, right? This is the best x-ray for maxillary sinus. This is a modified Waters view. Why am I calling it modified Waters? This is also called as Pierce view. The modification is that now we do an open mouth. So this is an open mouth Waters, also called as modified Waters, also called as Pierce view, which is the best for visualizing maxillary sinus. So look at this. These are the maxillary sinuses. You can see that there is an air fluid level here indicating sinusitis, right maxillary sinusitis in this case. This is how normal sinuses will appear completely black. Okay. Another question which may be asked is how do you acquire this X-ray? So when we are actually having a straight face, right? If I'm just take an X-ray like this, the pterygoid plates are going to overlap the maxillary sinuses. So in order to free the maxillary sinus from the pterygoid plate, I'm going to have to pull up my chin. So what happens is, this is the image receptor. So what we do is we pull up the chin like this. So that way, the pterygoid plates are actually going to go down and the maxillary sinuses come up. So just to give a diagrammatic representation, not a great diagrammatic representation, but will do the job. This is the image receptor. Imagine this is the patient, okay? So the angle between the chin and the image receptor is around 37 to 45 degrees. This is a repeat question, very weird repeat question. I mean, I don't know why they had to ask this, but the logic, I hope you understood. We have to lift the chin out so as to free the maxillary sinus from the bowl. So this is how we acquire a Waters view. On the other hand, look at this X-ray. So normally when you keep your face straight, this is how the X-ray will result. Can you appreciate it? That I have bones over the maxillary sinus. This is what is done to view the frontal sinuses. So this view here is the Caldwell view, and Caldwell view is the best for frontal sinus. Now, all of these X-rays are good questions for the exam, but in practice, we don't really do these views anymore. You know, sometimes some centers do Waters, but that's it. The investigation of choice for paranasal sinuses is NCCT/high resolution CT. So remember, the best investigation is HRCT, that is done in practice to visualize paranasal sinus pathologies. So now let's have a look at the questions from here. So what is the management of choice for aneurysms performed by interventional radiologists? So as we said, we are going to be doing coiling. Don't get confused by clipping. Clipping is a surgical approach. So a surgeon can externally also clip the aneurysm. So this is what is done for very, very big aneurysms which have a broad neck, but the preferred method done by radiologists, endovascular, is coiling, okay? Which of the following associated with banana sign on ultrasound? So banana sign is seen with spina bifida. So this is where, can you look at these antenatal ultrasounds? So this is where you can see the bifrontal constriction here. This is what is called as the lemon sign. And the cerebellum has this contour of a banana here. So lemon and banana sign are associated with Chiari malformations actually. So Chiari malformations also can be referred to as spina bifida. So that is where you see lemon and banana sign. Next, a 34-year-old woman landed up in AIIMS emergency after an RTA with a GCS of 3, minimum GCS. She is intubated. Any patient with a GCS less than 8 is an indication of intubation because that's severe head trauma. And NCCT was found to be normal. At such a low GCS, when the NCCT is normal, what do we suspect? We suspect a diffuse axonal injury, right? Which of the following is most likely due to rupture of saccular aneurysm? We know it, it's an arachnoid hemorrhage. 10-year-old boy presented with seizure and fell unconscious. Imaging is done. What's the diagnosis? This is what a lot of students got wrong. They were like, ma'am, NCC you said should be starry sky, multiple. But what did we see here? We see that there is a lesion with a central eccentric scolex. So when you see this focus of calcification here, this is what is the hallmark telling us it is NCC. So when you have a single NCC, it can present with a focal seizure. When you have multiple NCC, it can present with generalized tonic-clonic seizures, right? So this is an NCC, and that is by this foci of calcification eccentrically. Next, what is the structure marked in the CT scan? So this was apparently, students found this to be a tough question, but let's see if you can eliminate, even if you can't really answer this prospectively. So this is a CT scan of the paranasal sinus. First of all, these are the maxillary sinuses, and you can see that there is this polypoidal thickening of the left maxillary sinus. These are the inferior turbinates. These are the middle turbinates. You can see that on the left side, the middle turbinate has some air. So pneumatized middle turbinate is called as concha bullosa. So this is a middle turbinate which has air in it, right? Now look at what they have pointed towards. First of all, what is cribriform plate? The central piece of bone that you see here is the crista galli, and the two thin plates of bone, the roof of the ethmoid sinus, are the cribriform plate. So this is the cribriform plate surrounding the crista galli. So what has been marked, it's clearly not the cribriform plate. Now my question to you is, are we anterior or are we posterior? You can see the complete orbit here. You can see the maxillary sinuses. All of these are anterior structures. If I go behind, I'm going to see the optic nerve, and that is where you will have the posterior ethmoidal canal. So both of these can also be ruled out that it's not posterior. We are anterior. I'm not going to be seeing optic nerve here where you can see the globe, isn't it? So this is where you're seeing the globe. So I can't see the optic nerve at this point. So what is this? This indeed is anterior ethmoidal canal. So nobody expects you to tell anterior ethmoidal canal, but they just want you to rule out the others, right? So that's what you need to know in paranasal sinus. Apart from this, I've also taught you about ethmoidal air cells. In ENT, BTR, we have discussed that, but still just to confirm, on the medial aspect of the orbit is the largest ethmoidal air cell, which is bulla ethmoidalis. Infraorbital, which can be a variant which may or may not be present, is the Haller cell. Posterior ethmoidal air cell, which is in association with optic nerve, is the Onodi cell. So these are the cells you want to know about: Haller, bulla ethmoidalis, and Onodi, right? Next, what is this investigation here? So you can see there is contrast within the spinal canal. This is called as myelography. This is done previously when we didn't have MRI, so they would put contrast in the spinal canal if there is a tumor that will cause some filling defect. Obviously, this is not MCU. If you know what MCU is, this is nowhere close to bladder. What is vertebroplasty and vesselplasty? So vertebroplasty and vesselplasty are where you inject bone cement in the vertebra. Vertebroplasty is plainly injecting the bone cement, whereas vesseloplasty is where you're going to put this balloon sort of a structure and then you're going to put cement inside it. Both of these are used for vertebral fractures, compression fractures. We use it to strengthen the vertebra. So this is a myelography. 2-month-old infant brought to the OPD with a parietal swelling since birth. X-ray was ordered and is shown below. What is it? This is where a lot of students get confused. First of all, this is a lesion where you can see this thin rim of calcification. As soon as you see this, it cannot be caput subsidina. Caput is just edema. It resolves in a day or two. In 1 to 2 days, it resolves. Can't be caput. It can't be encephalocele. Encephalocele is brain herniation. It will not be a well-defined lesion. Kephalem hematoma versus subgaleal hematoma. Subgaleal hematoma is diffuse. It can be a complete scalp swelling. Nothing can stop a subgaleal hematoma, so it can go and have the entire scalp involved. So that's why it will not be a focal swelling. It will be a diffuse swelling. Kephalem hematoma fits everything. It is a focal swelling. The hematoma resolves to form this small calcified swelling here. So the answer is Kephalem hematoma. Identify the mark structure. A lot of students mark this incorrectly, but look at the density. Is it basal ganglia or is it internal capsule? So you can see this is darker. What is darker is white matter here. So you can see this is the thalamus, this is the lentiform nucleus, this is the caudate, and what has been marked where the arrow exactly is the internal capsule, and lateral to it lies the external capsule. So this is the internal capsule here. Next, chronic ear discharge, headache, ear pain, there is an abscess. Where is the abscess? So again, you can see this is the pons, cerebellum, temporal, frontal. So this is a temporal abscess, right? So if it was here, it would have been a frontal abscess. If it was here, cerebellar abscess. Next, 10-year-old child presents to the ED with vision loss in bilateral temporal fields. Means we localize it to the optic chiasma. Optic chiasma meaning bitemporal hemianopia, right? So child, and look at the CT. You can see that there is a cystic lesion with calcification. These white foci are calcifications. What is it? C for craniopharyngioma. Pituitary adenoma is seen in adults. It's a solid enhancing lesion, not a cystic lesion with calcification. Rathke cleft cyst is usually very small, intracellular. It will not expand to block the optic chiasma. And meningioma, we'll see a dural tail, we don't see any of it. With this, we complete neurorad. Now we go into musculoskeletal radiology. A lot of overlap with what you study in orthopedics also. So if you've done ortho already, it'll be like a revision. If not, I would advise you to do ortho immediately after this. So that will be a revision. Okay. So before I go into anything, I just want to brush up on the thumb rules here because that's important. Now, anything to do with bone cortex, right? So your fractures, osteoid osteoma, which was a cortical-based lesion, we will rely on CT. But when we talk about the bone marrow, when we talk about bone marrow, when we talk about cartilage, when you want to see ligaments, when you want to see soft tissue, then my reliance is on MRI. So this is what is the basic concept of imaging in MSK radiology. With this background, we start with bone tumors. In bone tumors, first off, you now have understood that investigation of choice for bone tumors is MRI because we want to see the bone marrow involvement, but you want to be shown the MRI. What you need to know is on the X-ray, how do I make a diagnosis? For that, where you always, never jump to diagnosis, you always start off with the location. That's the first step you have to follow. You will see whether it is epiphyseal, metaphyseal, diaphyseal. What does that mean? If this is the bone, if it is attached to the joint surface, it is epiphyseal. In between is metaphysis, shaft of the bone is diaphysis. So the first step is to see this. If it is epiphysis reaching the joint, that is epiphyseal tumor. You have to consider 2 DDs. Remember ECG. So if it is a child, C for child, C for chondroblastoma. So if you see an epiphyseal tumor reaching the joint surface in a child, even if they don't give me this is a child, I can see that the growth plate is not fused here. So this has to be a child. This is a chondroblastoma. On the other hand, if they give me an adult patient here who's around 30 to 40 years of age, and you can see it is reaching the joint surface, the other feature here is the soap bubble matrix. This is what is a giant cell tumor. Perhaps the most commonly asked question in the history of entrance exams is this. Don't get this wrong. If you see 30 to 40-year-old patient with an expansile lesion, epiphyseal lesion with a soap bubble matrix. This is giant cell tumor. The other name of giant cell tumor is osteoclastoma. So the osteoclasts are the giant cells of the bone. So this is osteoclastoma. Is this clear? So remember, ECG, epiphyseal is chondroblastoma or giant cell. Age will do the job for you, right? Moving on to diaphyseal tumor. You know how in BTR you would have studied vowels stick together. That's what I keep saying. All three vowels are diaphyseal tumors. So the first one is where they'll give you the history that there's a patient who has nocturnal pain that is relieved on taking NSAIDs. Why so? That is because in these tumors, you have a nidus that leads to formation of prostaglandin E2. You can remember pain, you do E. So E is PGE2. Because NSAIDs will block the production of PGE2, you have pain relief on giving NSAIDs. So the diagnosis becomes osteoid osteoma. So this is what you need to remember. Osteoid osteoma has a nidus. So it's a very tiny lesion. On an X-ray, you will just see some bit of cortical thickening here. On the CT, remember we said this is cortical based, and that is why this is the only one where investigation of choice is actually a CT scan. So on the CT, you can see there is thickening of the cortex, and sitting in the cortex is this small nidus here. The gray part is the nidus which releases the prostaglandins. So this is osteoid osteoma for you. Unique diagnosis, unique treatment. Now, this is a benign lesion, right? Osteoid osteoma. It is not going to do any harm to you except for the pain. So can I just burn the nidus and not remove the lesion? Yes. So that is why the treatment here is radio frequency ablation. All you do is ablate the nidus. So that is what you need to know from osteoid osteoma. Look at this diaphyseal lesion, huge mass. So they'll give you that there is a child here, a child in the first or second decade having a huge mass. You can also see that the periosteum is interrupted. Another misconception students have is that whenever you see onion peel, only then will it be Ewing sarcoma. When you see such a triangle, it is osteosarcoma. Not really. Codman's triangle, onion peel, all of these just represent aggressive tumors. They are periosteal reactions representing aggressive growth. So it's not necessary that every time you are going to see the onion peel, every time Codman triangle is osteosarcoma. No, both of them just tell me it's a malignant lesion. So here you can see this incomplete periosteal lifting indicating a very aggressive lesion. So an aggressive lesion in the diaphyses of a child is Ewing sarcoma. So this is Ewing sarcoma for you. This is the most radio sensitive tumor. This is also the most chemo sensitive tumor. So basically the management is going to be a combination of chemo plus radiotherapy. So this is Ewing's sarcoma. In PATH, we also studied translocation 1122 with this. You know the markers are CD99, MIC2. You need mnemonic, you can remember 11 2 are 22, 11 table is 99. So that's how we can remember all of these features. Third diaphyseal tumor is pathognomically seen in the tibia here. So tibia with associated bowing, there may be anterolateral bowing of the tibia in a lot of cases. This is adamantinoma. So this is adamantinoma seen in tibia. So diaphyseal tumors, as I said, three vowels stick together, right? So this is about diaphysis. Talking about metaphyseal tumors, so look at this lesion here. You can see, first of all, the epicenter is in metaphysis, right? You can see white colored matrix because this is a bone-forming tumor. You can see how there is this sunburst reaction. You have spicules which are going parallel along the blood vessels. So this is the sunburst periosteal reaction. You can see how the periosteum is lifted off like this to make this Codman's triangle. So what is the diagnosis? This is osteosarcoma. So osteosarcoma, you will see sunburst periosteal reaction, Codman's triangle. This is osteosarcoma. Most common malignant primary bone tumor here. This is the most radio-resistant bone tumor. So this is the most common radio-resistant bone tumor, right? So this is osteosarcoma. Two cysts that you can see here. Here you can see, first of all, in both of these, that they are metaphyseal. The growth plate is not yet fused. You get this lesion. You don't see any matrix here. So this is what is a simple bone cyst, SBC, simple bone cyst, also called as a unicameral bone cyst. So SBC or UBC may be mentioned here. And what you can also see associated with it is a fracture. A fracture in the setting of a bone tumor is what we call as a pathological fracture. So this is a pathological fracture, and you can see the fracture fragment is actually floating here, which is called as the fallen leaf sign, also called as the trapdoor sign. So trapdoor sign, fallen leaf sign seen in simple bone cyst. On the other hand, when you see that there is this soap bubble appearance that we saw in GCT, very similar to it, but then this is metaphyseal. Lots of students confuse GCT with ABC. GCT, you will see in epiphysis, reaching the joint, whereas this is unfused. This is in meta. This is the epiphysis here, right? So this is a metaphyseal lesion. This is the aneurysmal bone cyst. So ABC, aneurysmal bone cyst, is metaphyseal. Three more tumors, very, very important. When you see a tumor growing out of the bone like a mushroom here, this is what is called as exostosis or osteochondroma. The name itself tells you that there are two components to it. One is the bony component that you can see on the X-ray, and the other is the cartilage. The cartilage is something, as we saw, is not detected on X-ray or CT. We need MRI to see cartilage. So look at the MRI here. Can you see how, like a mushroom, there is a bone tumor growing out, and then we can see the cartilage cap. But you'll be like, ma'am, I could already make the diagnosis in the X-ray. Why did we have to see the cartilage cap? The cartilage cap is very, very important because these tumors have a risk of developing chondrosarcoma. So they tend to become chondrosarcoma, and for that we need to monitor the thickness of the cartilage cap. So what we do is we measure the maximum thickness here. The moment this thickness becomes more than 1.5, some people also use 2 centimeters, whatever is given, you can accept. So more than 1.5 centimeter, what you have to do, you need to remove it. So we keep monitoring these patients on MRI. If the cap is more than 1.5 centimeter, that is an indication of surgically removing this osteochondroma. Whenever you see the hand of a patient, hand, you remember AN, make it EN. So this becomes enchondroma. So this is enchondroma. Usually you will see multiple enchondromas in the multiple short bones of the hand. This syndrome, when you see multiple enchondromas, is called as Ollier's syndrome. If they give you, the patient also has blue lesions, skin lesions, which are hemangiomas in addition to enchondroma, the syndrome becomes Maffucci syndrome. So we have Ollier's syndrome and we have Maffucci syndrome in addition when we have hemangiomas. Look at this X-ray here. You can see that within the metaphyses of femur, there is a lesion which has this ground glass matrix. We have seen ground glass in COVID. This is ground glass of the bone. And whenever you hear ground glass, you have to think of fibrous dysplasia. This fibrous dysplasia can cause the femur to be twisted as such. And this is what is called as the Shefford-Crook deformity. Apart from this, you want to remember, if they give you that the patient also has endocrinopathies, precocious puberty, the syndrome that is associated is McCune-Albright syndrome. So McCune-Albright syndrome, Shefford-Crook, ground glass, all of these are your buzzwords for fibrous dysplasia. One more tumor here where they show you the flat bones getting involved, and this huge tumor here having this sort of a stippled calcification, also called as ring and arc popcorn calcification. So when you have this is what is indicative of chondroid matrix. So this is chondrosarcoma, malignant tumor that frequently affects the flat bones like the pelvis, chest wall. Those are the usual sites of a chondrosarcoma. This is the classic matrix of a chondrosarcoma. Now we are going to be seeing a bunch of spine X-rays and understand how to differentiate them. So these are the 2 images that we need to do here. So the first spine, you can see that there is this alternating white and black pattern that you are seeing. So this is what is called as the Ruger-Jersey spine. So this Ruger-Jersey spine, these alternating sclerotic and lytic bands are what you see in secondary hyperparathyroidism. So this is a feature of secondary hyperparathyroidism, also called as renal osteodystrophy. Why and how and what are the metabolic changes? I taught you in renal system of BTR. So that is what is CKD related spine changes, Ruger-Jersey spine. When you see that there is this white bone here, like ivory, right? So this is what is called as ivory vertebra. Independently, this can be seen in many conditions. 1DD is Paget's disease. You know how in Paget's you have blastic phase, lytic phase, mixed phase. In the blastic phase, you will see this ivory white appearance. This can also be seen in Hodgkin's lymphoma. So Hodgkin's lymphoma is another DD. And very, very important is there can be blastic metastasis. 2 primaries which give rise to blastic metastasis. One is breast CA in women and prostate CA in men. Both of these are causes of blastic metastasis, and something linking both of these. The spread of metastasis to the spine is also common. Both of them spread via the epidural venous plexus, which is called as the Bateson's plexus. So both of them reach the spine via the Bateson's venous plexus. So this is what you need to know about white ivory vertebrae. 3 differentials, Paget's, Hodgkin's lymphoma, blastic metastasis. Look at the third spine X-ray. What can you see? You can see that the density of the bone is gone. The bone is not even looking white. It's looking completely black. And because the bone is so weak, look at how bent the bones are. It is looking like a codfish mouth. So this codfish mouth appearance is what you see in osteoporosis. Osteoporosis is a generalized reduction of bone mineral density. The metabolic levels, calcium, phosphate, PTH, LP are all normal here, right? So that is what is very, very important, that this is a generalized reduction of bone mineral density as the age of the patient increases. So frequently they'll give you that this is a post-menopausal female here. So this is osteoporosis. Remember, the investigation of choice is a DEXA scan. DEXA scan, you know, stands for dual energy X-ray absorptiometry. So what we do is I take the bone mineral density of our patient and we compare it with a young adult's density. Young adults wear t-shirts, isn't it? So that gives us a t-score. So when I compare the density of my patient with a young adult's bone mineral density, we get a t-score. Any t-score below minus 2.5 standard deviation is what is the definition of osteoporosis. So this is the definition you need to keep in mind. Next case, you can see that there is a young male here. They'll tell you the patient has inflammatory backache. The moment you hear young male, look at the spine. The spine is completely fused. It's looking as if it's a bamboo spine. It's a fused bamboo spine. You can see the spine getting completely fused. You can see here the interspinous ligament is ossified. What is the diagnosis? This is ankylosing spondylitis. So remember, ankylosing, you can just remember ankspond. Ankylosis means to fuse. Spondylitis is inflammation. So this actually starts off with sacroiliitis. So the earliest finding here, remember, is actually sacroiliitis. yes, the sacroiliitis can be picked up on an MRI. So the investigation of choice, or the most sensitive investigation of choice, is MRI, and then it involves the spine, where the spine becomes completely fused. HLA-B27, as you know, is associated. Various name signs fused like a bamboo. You can see a tram track appearance. This interspinous ligament ossification is what is called as a dagger sign. So these are the various signs which are associated. You can also be given history of uveitis, red eyes in the patient, bilateral heel pain. Bilateral heel pain is because of associated enthesitis. What is enthesitis? Wherever you have attachment of tendon and ligament, that site becomes inflamed. For example, if this is the calcaneum, the point where the Achilles tendon has to insert, it becomes inflamed. Looking at the next image, so you can see here in the spine that there is a lateral curvature which is associated. So this lateral curvature of the spine is what we call as scoliosis. They frequently ask you what is the angle that is being measured here. So this is what we call as the Cobb's angle. So this is the Cobb's angle, which tells us about the severity of scoliosis. Two more spine x-rays. So here, if I give you a hint that this patient has black discoloration of pinna, sclera, what is that? That is called as ochronosis. So ochronosis is basically calcification of the cartilage, blackish discoloration, and that's the radiological finding which has been tested here. You will see that the intervertebral discs here are calcified. People frequently confuse it with Anspon's. Nothing to do with Anspon. What you see here is the calcification of the intervertebral disc, right? So that's ochronosis. On the other hand, if you see such a spine appearance where there is this flowing ossification along the anterior longitudinal ligament, so ALL is the ligament connecting the anterior part of vertebral bodies. When you see that there is this new bone formation along it in an old patient more than 50 years, this is what we call as DISH. DISH stands for diffuse idiopathic skeletal hyperostosis. So essentially the only useful word here is hyperostosis. There is new bone formation like a flowing candle wax along the anterior longitudinal ligament in an old person is DISH. This is also called as Forestier's disease, right? So this is what we need to know. Now a pattern approach to this, when they give you a 5-year-old boy, low socioeconomic status, low bone density. So two causes of low bone density are rickets and scurvy. Both of them have different problems. In both, ultimately the bone is not forming, but in the rickets, the problem is you don't have calcium. There is no vitamin D. Because there is no vitamin D, or low vitamin D, there is low calcium. So how this presents is a deficiency of calcification at the growth plate. So what happens at the growth plate, you're going to have your chondrocytes which are waiting. This is the zone of provisional calcification. That is where calcium was supposed to come. It's not there. So now all of my chondrocytes are waiting, creating pressure on the metaphysis. That's why the metaphysis becomes cupped, splayed, and frayed. There is cupping, splaying means separation, fraying means irregularity. So that is what you see in rickets. Because the calcification is not there, we have something called a zone of provisional calcification that remains deficient, and because of that, the resultant changes are going to be what you see at the metaphysis, namely metaphysis becomes cupping. There is cupping of metaphysis, there is splaying, and there is fraying. So these are the changes that we see. Once you give calcium in healing rickets, now what happens? The white calcification begins, and you may see a white metaphyseal line. But don't confuse this with the white line of Frankel that you see in scurvy. How not to confuse? Both are white line, but in rickets, the irregularity is going to persist. So the white irregular line is what is seen in healing rickets, right? So that is what is the sign of healing rickets. But in scurvy, when we talk about scurvy, we also have a smooth metaphyseal line. The smooth metaphyseal line is what we call as Frankel's line. So this white line of Frankel with a smooth metaphysis is the hallmark of scurvy. In addition, what you see here is a Wimberger ring sign. So this Wimberger's ring sign is a very, very well delineated epiphysis that you tend to see here. All right. So in scurvy, what is the problem? You know, there is lack of vitamin C, because of which the hydroxylation of lysine and proline doesn't happen. That is what vitamin C is a cofactor for. Because of absence of hydroxy, lysine, and proline, you don't have collagen. So now calcium is there, the osteoid matrix is not there. You know, collagen 1 forms bone, 1 is bone. You studied that in biochemistry BTR. So basically, I don't have collagen. So because of that, now again, the bone density is going to be weak. Essentially, I don't have bone. So these are the few signs. There are a few other signs as well. You see this spur here, or the bony outgrowth, which is called as the pelican spur, or this loosened zone here that is called as Trummerfield zone. Don't memorize these names, not important. Just have this background. We're going to look for this white line. Now, if I tell you another boy with short stature, but now the bone density is normal, what you see is that the metaphyses are again irregular and they have this V-shaped. Another finding you can see is that the femur is almost as long as the tibia, meaning the femur is shorter than it should be. So this is what we call as rhizomelic shortening. So this rhizomelic shortening is where you have proximal narrowing, right? So there is proximal shortening, which is noted, and this metaphyseal irregularity is what is the characteristic feature of achondroplasia. Instead of achondroplasia, they may also write it as metaphyseal dysplasia. So achondroplasia, metaphyseal dysplasia is irregular metaphysis with a normal bone density, and this sign is called as chevron sign. So this is the chevron sign here. So this is our approach to bone disorders, MSK radiology in general. Let's look at the questions. This was a rather unusual question that was asked in the last NICT exam. I mean, we can never diagnose a patellar fracture on an AP view, and that is what they gave in hindsight if you want to look at it. So this is a patella, and you can see that there is a fracture line here. So I don't know why and how this question has come. So this is patella fracture. Normally for patella, we will do what is called as a skyline view. This is what it will look like. This is not what it will look like, but basically you will see patella in view and there will be a fracture associated, okay? So that is how patella fracture appears. Next, a 5-year-old boy with inability to pronate and supinate. What you can see in the X-ray is a fusion of the ulna and the radius. You can see both of them have fused. This is an old FMG repeat question. This is radio-ulnar synostosis. Even if you have no idea what it is, just read the name. Ostosis means bone, syn means to fuse. There's no fracture that you can see here. There's no dislocation, right? So you can just rule out and reach the answer. 35-year-old male, pain, swelling, 35-year-old, epiphyseal, soap bubble. Please don't get this wrong. This is giant cell tumor. What is this here? You can see that this is the psoas muscle. There are these T2 hyperintense collections in the right psoas. This is what represents psoas abscess. So this is psoas abscess MRI. All of the following are useful in osteoporosis. DEXA is the investigation of choice. Bone scan has no role in osteoporosis, and we'll talk about bone scan in a few minutes. Chemical analysis is useful because we will find that all of the values are normal and it helps to rule out other metabolic bone diseases. Quantitative CT is a new investigation, not just quantitative CT. We are also now doing quantitative ultrasound. These are new investigations which are going to replace DEXA in the future because it gives you a full 3D volumetric bone mineral density. You don't really have to compare it with anybody. You can get an objective assessment. So these are 3 investigations that are used. So bone scan has no role in osteoporosis. Next image, there is a 40-year-old male with progressive forward bending and stiffness. What do you see? You see that the complete spine is fused here. There is this complete fusion instead of the X-ray we are used to seeing, showing you the CT scan where you can see fusion. Look at this posterior elements being fused and there's increased density. This is ANSPON. Rheumatoid arthritis, remember, will involve the atlantoaxial joint, leads to atlantoaxial dislocation. Doesn't involve the diffuse spine. Fluorosis will just have increased bone density of all the bones. A hallmark of fluorosis is the interosseous membrane, syndesmosis. So the interosseous membrane ossification is the hallmark of fluorosis. You're not going to be seeing fusion. Rita syndrome is a seronegative ANSPON. Basically, it's just like ankylosing spondylitis, but it involves peripheral joints more. It's a triad. You've learned this. Can't see, can't pee, can't climb a tree. Can't see meaning conjunctivitis, can't pee, urethritis, can't climb a tree, arthritis. So this is the triad of Rita syndrome. 70-year-old male presents with history of painful limb, no drug intake, no trauma. What is the diagnosis? So here you can see that at the hip joint there is irregularity. You can see the sclerosis and flattening of the femoral head, and you can see some lucency inside. So when you see femoral head sclerosis with this lucency, this is what is called as the crescent sign, and this is diagnostic of avascular necrosis. Usually AVN will have history of steroids or will have history of trauma. It's a bit weird that they have ruled that out, but it may be seen independent of that as well, but just telling you the risk factors for AVN. TB hip should have some sort of joint involvement. There should be some joint destruction there, which is not seen here. ANSPON, this is not ANSPON. ANSPON will have fusion of the SI joint. RA, rheumatoid arthritis, will have erosions. Again, it is an arthritis, so the joint should be affected. Here, it's not the joint, but the femoral head, which is affected. So that's what is the primary diagnostic criteria. Mark ligament, we studied this in ortho-BTR. This is what is the cruciate ligament. Now, cruciate ligament means it crosses. So when something crosses across the joint, it's cruciate. Is it ACL? Is it PCL? The naming is on the basis of where on tibia do they insert. If it inserts posteriorly on the tibia, it's PCL. If it inserts anteriorly on the tibia, it's ACL. So in this case, it becomes the posterior cruciate ligament. The menisci are going to be in between. They don't cross. And collateral, they will never ask you. They're very thin ligaments and it's seen in the coronal plane. Even radiologists have trouble finding it, so they're not going to ask you. So either it's cruciate or it's menisci that you have to remember. Moving on now to radiotherapy and nuclear medicine, the last miscellaneous part that we have to cover. They are general theory questions. You may get 1 or 2 questions from this, and they're usually straight one-liners. You can't afford to go wrong here. This has not been asked in a lot of years. If it does get asked, it's something you may not know otherwise. So that's why I'm teaching this. So what are the effects of radiation? Why do we say radiation is bad? So there are 2 kinds of effects you have to remember, stochastic and deterministic. The word stochastic means literally by chance. So these are not going to happen in everybody. It depends on chance. So there is no threshold. There is no threshold beyond which I will say that this patient will have this effect. It is a delayed effect. The classic example being cancer and mutation. So there is no threshold beyond which mutations start or cancer risk increases. So this is what you need to remember, that stochastic effects happen by chance, and these are all or none effects. Either you have a mutation or you don't have. You don't have a little bit of cancer. Yeah. So these are by chance. On the other hand, deterministic effects have a threshold that if you cross this threshold, you will get erythema, you will get cataract, you will get hair loss, which is epilation. And these happen immediately. As soon as you get radiation exposure, these will happen. So this is the difference between the two. Now talking about radiation units. So this is where you need to remember SI units as well as conventional units. First, let's talk about radioactivity. Radioactivity, the SI unit here is Becquerel. So Becquerel, the father of radioactivity, is SI unit. C for conventional, C for Curie. Curie is the conventional unit. The relation, no need to remember, but 1 Curie is 3.7 into 10 raised to 10 Becquerels, forget it. Coming on to others. Now we are talking about radiation per se. Suppose this is the radiation source. How much is the radiation that it is giving in the environment is the exposure. The SI unit is Coulomb per kg. How much charge per unit mass? That is the SI unit. Now the trick to remember, one was C is C. Now all of the other conventional units are going to be starting with R. So that's the first trick. So here, who is the conventional unit? It's none other than the father of radiology, who is Röntgen. Why Röntgen is father of radiology? Because he discovered X-rays, right? You must have seen the hand of his wife. So this was accidental exposure. He was doing some work and he found that, oh, it's a picture of my wife's hand. And that is how it led to the discovery. At the time, they didn't know what is going on. So that's why they called it X-rays, for which he was given the Nobel Prize in 1905. So Röntgen, the relation between the two, no need to remember. 1 Röntgen is 2.5 into 10 raised to minus 4 Coulomb per kg. Absorbed dose and air karma have the same unit. For that, you can remember ABG rad. What is ABG rad? You know how we integrate stuff, integrate ABG with radiology. So absorbed dose, SI unit is gray, R is conventional, so that's rad. So gray and rad. 1 gray is 100 rad. Equivalent effective dose thankfully have the same unit. SI is starting with SI, so that is sievert is the SI unit and REM is the conventional unit. So 1 sievert is 100 REM. Equivalent dose basically is for different radiations. For example, I have alpha rays which have maximum damaging power. Then I have gamma rays which have minimum damaging power. So how can I equalize them with the same unit? That is the equivalent dose. It takes into account the different radiations. Effective dose takes into account the different tissue sensitivity. For example, thyroid will have a different sensitivity as compared to the bone. So that tissue sensitivity is taken into account in effective dose. So if they ask me what is the most useful expression of radiation unit, that becomes effective dose. So this is what I need to know from radiation units. Now let's talk about maximum permissible dose. So this is how much dose are we allowed as radiologists and as public exposure. And here I'm not talking about investigations per se, I'm talking about the background radiation that we face. So if you're a patient, then these limits don't apply obviously. If you're undergoing a CT scan for some diagnosis, it doesn't apply. But what is the radiation that the background radiation constitutes? So overall for anybody working in radiology, it is 20 millisievert if you average it out over 5 years. But for a single calendar year, it is 30 millisievert. So 30 is a better answer. Whatever is there in the option, you mark. For public, Aam Janta, number 1 millisievert per year. Lens is the most radiosensitive part, so that's 150 for public, remove a 0. Skin extremities, it's 500, remove a 0 for public, becomes 50. This is what is very, very important. How much is the allowed radiation dose for a pregnant occupational worker? That is 2. You can remember 20 and then take out a 0, it becomes 2. Whereas for normal, it's normal. Any pregnant female is normal public, so that's 1 millisievert. Fetus, imagine half the radiation of the mother is shared by fetus, so that is half. So 2 divided by 1, 1 divided by 2. So don't remember both. Essentially, the takeaway here is 1 millisievert, 20 to 30, and 2 millisievert, and you are sorted. 2 images that can be tested. So what is this here? This is what we call as a TLD badge. TLD badge is the badge used for personal dosimetry. So this is what measures the radiation to occupational worker. This is thermoluminescent dosimeter. So thermoluminescence is the principle. The compound that is used to make it is calcium sulfate, which is having this dysprosium compound in addition. That is what is used in India. Apart from this, even lithium fluoride can be used, but the former is cheaper and that's why we prefer that. So this is thermoluminescent dosimeter. A radiologist is going to wear it, and every 3 monthly, this is what is submitted for reading. So in the last 3 months, how much is the exposure that I've had is measured by the TLD. So every 3 monthly, we have to submit it and the dose is calculated, right? Where do I wear this badge? So we're going to wear it near the collar pocket, above the lead apron or below the lead apron. So this is the lead apron that protects me by absorbing the radiation. So where should I wear it? So obviously we want to know how much I am getting, not how much apron is getting. So I'm going to wear it below the lead apron at the chest level. So that is the first thing. The thickness of lead apron, they asked, the most common thickness is 0.5 millimeters, whereas the minimum thickness of a lead apron is 0.25. Both have been asked, so most commonly 0.5, minimum thickness 0.25 mm. Now let's venture into, so this was a general radio that we had to do. Now we venture into nuclear medicine. So first of all, I want to tell you the concept of nuclear medicine. We have these technetium-99m studies. So these are technetium-99m scintigraphy studies. For example, I want to know about parathyroid adenoma. What I do is I link this technetium-99 with a compound called Sestamib. This Sestamib has a property to go to parathyroid adenoma, if any. My technetium has been clubbed with it, so technetium also tags along. Wherever there is parathyroid adenoma, both of these guys are going to bind to it, and the technetium is then going to emit gamma rays. So that is what my gamma camera will detect. If there are gamma rays being emitted here, they will be detected as this hotspot. So such a study is called a scintigraphy study. Same thing, I give technetium Sestamib and now I do a CT scan instead of gamma camera. There are both. There's a gamma camera with a CT scan. Now I can get a 3D localization, isn't it? I'm also seeing a CT in the background along with that hotspot. So now I know the exact site of where this parathyroid adenoma is. Such a study is called a SPECT study. What is a SPECT study? It stands for single photon. Photon is the word you need to remember. Single photon emission computed tomography. So this is where I've combined my technetium study with a CT scan, and that gives me the exact 3D localization of the parathyroid adenoma. So if I ask you, is a technetium Sestamib scan better or a technetium Sestamib SPECT better? You'll be like, ma'am, obviously you're giving me a CT in addition, so it's SPECT. So this is what was tested in INICT, right? So if SPECT is there, mark SPECT. If SPECT is not there, just technetium Sestamib. So these are a few nuclear medicine scans that you need to know about, and I'll tell you the applications of each. So technetium-99 MDP. Everywhere we have the same technetium because that's my gamma emitter, and then I tag it with a compound which will take it to the target organ. So I hope you got the concept. So technetium MDP is what we use for bone scans. Look at the image first. So this is how a normal bone scan will appear, wherein there is no particular hotspot. All of the bones are diffusely symmetrically taking the compound, and you can see it's getting excreted from the kidneys into the bladder. Now, if there is any area where there is abnormal bony turnover happening, for example, metastasis or a primary bone tumor, you will see these hotspots. So this is where you can see these multifocal bony metastases presenting as hotspots on bone scan. So that is how bone scan is going to pick up multifocal metastasis. So hotspots will be seen in mets, it will be seen in bone tumor, essentially anywhere bone turnover is happening, like a fracture, like a metabolic bone disease, right? But what is very important is cold spot is the characteristic of multiple myeloma. So when you have a lytic lesion but the bone scan does not show increased uptake, that is what we call as a cold spot, and that is a feature of multiple myeloma. This was a recent question where they asked, what is a super scan? So a super scan is an investigation where all of the bones are taking up so much uptake. Look at this, that even the kidneys are not seen. So this is a super scan where all of the bones are showing diffusely raised uptake, and this is what we see in metabolic bone diseases because now all of the bones of the body are affected. The other theoretical possibility is where you have many metastases. All of the bones have multifocal metastases resulting in super scan. So that is what you need to know about bone scan. HIDA, I already said, is for the biliary system. So one, we had addressed that how it is having high accuracy in acute cholecystitis where you will not see the gallbladder. Second application is in bile leaks where they are very sensitive, but it does not tell you the site. It can't localize the site of the type of the bile leak. And the third application is extrahepatic biliary atresia. In biliary atresia, HIDA scan can be used as a rule-out modality. If HIDA is normal, it means it can't be BHBA. But if HIDA is abnormal, then I'm not very sure. It can either be biliary atresia or it can be hepatitis. And that's why the gold standard for extrahepatic biliary atresia is an intra-op cholangiography. You have to puncture the CBD and see whether they are patent or not. Sestamib, multiple times asked, almost every year in one of the exams, this questions will come. This is parathyroid adenoma. Investigation of choice is a Sestamib scan. Sulfur colloid scan is used to pick up the reticuloendothelial system. In the liver, if you see a hotspot, there is one tumor which has the presence of Kupffer cells, which are macrophages. So if you see a hotspot on a sulfur colloid scan, that diagnosis becomes FNH. FNH stands for focal nodular hyperplasia. So FNH is a lesion with a central scar, and you will see a hotspot with the sulfur colloid scan. Technetium pertechnate is the investigation of choice for Meckel's diverticulum. Okay, so Meckel's diverticulum, painless GI bleed, remember technetium pertechnate. In addition, in Warden's tumor, salivary gland tumor seen in smokers, you have pertechnate showing us a hot spot. Fine, so that's pertechnate. We have two renal scans. DMSA, the name tells you everything. It's a static scan. It's like taking a picture of the kidney. It's a static scan, or M for morphology scan. So it tells us about the activity of the compound in the kidney, and if there is any non-functional area, that is going to be called as a scar. So this is the investigation of choice to pick up renal scarring. That is DMSA, DTP and MAG3 tell us about the function. So these are functional scans or dynamic scans, which tell us about the functional excretion and whether or not there is any obstruction happening in the kidney or not. So they are the investigation of choice for functional or dynamic ability of the kidney. So now we talk about PET scan. Again, lots of questions come from PET scan. So what you can see here is a combination of not just PET but also CT alongside, which is done most commonly. So this is what we call as a PET CT. It's a hybrid investigation of nuclear medicine as well as radiology. What does PET stand for? So PET stands for positron emission tomography. Positron emission tomography. So this is where I use a compound that is 18-fluorodeoxyglucose. 18-fluoride. 18-fluoride is what is used as a positron emitter. Deoxyglucose is the carrier. So you know how the cancer cells in the body are all relying on glucose preferentially, right? So these are the cancer cells here which are preferentially utilizing glucose by glycolysis, which is anaerobic glycolysis. That is a bit controversial whether it's anaerobic or aerobic. Decide whatever you want to. So this is Warburg effect, right? So the cancer cells, when I inject glucose in the body, they are preferentially going to take up that glucose. And along with the glucose goes our positron emitter. So somehow my fluoride has landed up in the cancer cell. Yeah. Now what happens is this fluoride will emit the positron. We have a lot of electrons, so the positron combines with the electron, and when this reaction happens, that is called as annihilation, and that results in the production of these two gamma rays of 511 kilo electron volt. And then when I put my patient inside the scanner, it is going to detect these two gamma rays, and that's how we localize that, okay, these are perpendicularly released, so this must be the site. And that's how we realize that, okay, this hotspot is the tumor or metastatic focus. So that is why PET scan is the investigation of choice to pick up any metastasis. Very, very important. Few points here. Glucose, because the whole point is glucose, we have to make sure that the patient has normal sugar, right? This will give you deranged results in patients whose sugar values are not in the normal range. So if you have a diabetic patient, you need the patient to be well controlled before you can do a PET scan. That's the first point. Second point, any place which is inflamed can also show preferential taking up of the glucose. So a frequent false positive is tuberculosis, especially in a country like ours. There are many cases of TB. Active tuberculosis can also show you a false positive PET workup, and you can see a false negative, meaning you have a tumor but still the PET is negative. That is a typical carcinoid. So typical carcinoids tend to give you a false negative with PET. So that's a repeat question again. So 18-FDG PET, we said, is the investigation of choice for metastasis. There are a few special PETs you should be knowing about. So sodium fluoride PET is particularly useful for bone metastasis. It's the investigation of choice for bone metastasis. This is an FMG question, last year question. Choline or PMSA PET is something that is very, very useful in prostate CA. PMSA stands for prostate membrane specific antigen. DOPA PET is what you see for pheochromocytoma. Dotanok PET is used in neuroendocrine tumors, very, very important potential question. And C11 Pittsburgh compound is a recent advance that is being done for Alzheimer's dementia. So few recent advances, potential questions from PET scan. Moving on to radiotherapy now. So here what you need to remember first of all is the difference between a teletherapy and a brachytherapy. Teletherapy means we are giving the radiation from a distance, right? Telemedicine, teleradiology, from a distance. So from a distance I am giving radiation to the patient. Brachytherapy means you are going inside the tumor and giving radiation. For example, if there is a prostate CA, you put these radioisotopes inside the prostate. So that's what is brachytherapy. Brachytherapy has the advantage that the surrounding organ damage is reduced, right? So the surrounding organ damage is reduced because you are going inside the tissue. But in teletherapy, everything in the line of the tumor will be irradiated. So that's why brachytherapy is better when you have a tumor, right? The only exception being a very large tumor. If it's a very large tumor, brachytherapy may not be effective. The disadvantage is when I'm putting the radioisotope now, the operator may get exposed to the radiation. So how can we avoid that? So that is a repeat question. This technique that is being shown to you here is what is called as remote after loading. So this remote after loading means that first the surgeon is going to put this grid and put empty pellets inside, and then using a robotic arm, we are going to place the radioisotopes. This technique of remote after loading is used for brachytherapy. That's a question you want to remember. Now, what is this machine that we are using to give teletherapy? So the machine that you can see here is a LINAC. A LINAC stands for a linear accelerator. This is what is being used most commonly now to administer radiation. Linear accelerator is used to make X-rays as well as electrons. X-rays are now the most common mode of radiotherapy. That is the most common agent of radiotherapy. Previously, we used to use nuclear reactors to give us gamma rays from cobalt, cesium, but X-rays are better because it's a machine. You can switch it on and off when you like. Cobalt can't be switched off, right? So that's what you need to remember, that linear accelerator is now being used most commonly. Cyclotron is something that is used to make protons. This is something which is very expensive, very new. We have only one cyclotron in India, which is in Apollo, Chennai. It's not even there in AIIMS. So cyclotron is used for protons. Now, why so expensive? It is expensive because of its special property. See, X-ray, gamma rays, everything else has this property that as the distance from the tumor increases, the effectivity keeps decreasing. But protons have a very unique effect. They have a big peak deep into the tumor. This peak is what is called as the Bragg's peak. Means they are very effective deep into the tissue, meaning their surrounding organ damage. For example, normally if I give gamma rays through my skin here, skin will have maximum radiation and then it travels down. But protons have no superficial damage. They're going to have their peak deep into the tissue, and that is called Bragg's peak. So both are questions: cyclotron producing protons, Bragg's peak property of protons. Okay. So this is about the mode of radiotherapy. Now let's understand this particular image here. So this is what is called as gamma knife. Gamma knife is a hybrid of neurosurgery and radiotherapy. So this is what is called as stereotactic radiosurgery. This is just like doing a surgical strike. Do you understand surgical strike against a terrorist? What we need to do is know the exact coordinates of the terrorist and attack there without any collateral damage. That's what we want for a tumor. For an intricate area like brain, I want to attack the brain tumor without collateral damage to the surrounding organs. What do we need for that? We need coordinates.